Well, welcome everyone. Thanks for going ahead and jumping in with introductions in the chat. Again, my name is Margareta Brandt. I'm an Assistant Deputy Director for Health System Performance here at OHCA, and I use she, her pronouns. And this is our 25th meeting, the OHCA Investment and Payment Workgroup, and our 13th meeting focused on behavioral health investment. And we're looking forward to a discussion today focused on finalizing at least a draft of our definition of behavioral health spending. So for our agenda today, we will give a brief summary of the status of OHCA's work on measuring and setting a benchmark for behavioral health care spending. And then we will spend most of our time reviewing the definitions for claims and non-claims behavioral health spending, including some remaining questions we have for you all, and really are interested in your input on a few different questions throughout the presentation. And especially we'll return to the behavioral health and primary care module and look at some of those details. And then before we sign off, we will look at a detailed timeline for completing this phase of the behavioral health work and preview some proposed next steps for the work group. And as always, just a brief recap of our format and a reminder that we appreciate all of the feedback in the chat, and we try to work through it during the meeting, but if we're not able to work through it, the OHCA team reviews it all and uses it to inform our work going forward. And then another just quick reminder of our work group members and the range of perspectives that they represent. So with that, I think we can jump into our first agenda item, which is just an update on the status of our behavioral health work. So, based on all of your input and all of the presentations we've made to the OHCA board and advisory committee, there's been lots of activity over the past few months around our work to measure and benchmark behavioral health spending. And so we thought it would be helpful to briefly summarize where we stand now. And as we usually do, just a quick reminder of our statutory mandate, which is to measure total behavioral health spending relative to total healthcare spending and to set benchmarks for levels of behavioral health spending. And the benchmarks are intended to promote improved outcomes and motivate increased capacity and innovation and improvement in behavioral health care. So where we are now, so for measuring our work to measure behavioral health spending, payers will submit data on behavioral health spending for the first time in fall of 2026, so next fall. And this data will cover the years of 2024 and 2025. And OHCA plans to release the first report on 2024 and 2025 behavioral health spending in summer 2027. And according to statute and regulation, entities required to submit data for this purpose are payers and fully integrated delivery systems that cover a minimum of 40,000 lives in the commercial, Medicare Advantage, and/or Medi-Cal markets, Medi-Cal managed care markets. And then continue on with some updates about measurement. So starting next year, payers will submit data on claims and non-claims payments for behavioral health care using the definitions that OHCA develops through this work group, and the detailed methodology will be included in an updated data submission guide for payers that OHCA will release in spring of 2026. And the data will be aggregated by performance year and market category. And then also want to note that the Healthcare Payments Database, or HPD, can support analysis of behavioral health spending or utilization at a more granular level to complement OHCA's broader spending data collection. And we'll look at some of the potential analyses that OHCA plans to explore using the HPD at next month's workgroup meeting. Um, and then just a few more notes that, as we discussed in the work group, spending will be sortable by service categories and subcategories for analysis and reporting purposes. And this will include the ability to identify spending for mental health and substance use disorders separately. And then also specifications for the behavioral health and primary care module will be included in this updated data submission guide to make sure that we can measure behavioral health and primary care both as part of primary care spending and part of behavioral health spending. And yeah, it looks like Kevin has a question. Kevin, go ahead.
Just a quick one, Margaret, if you go back to the slide 7, just one quick question about Medi-Cal. So we have Medi-Cal managed care plans. What percent of Medi-Cal beneficiaries are in managed care plans? I'm kind of wondering about the non-managed care side of Medi-Cal and why that's not in scope and how big that is for Medi-Cal.
I I can answer that.
Thanks,
I
Jeff.
don't Yeah, I don't know the exact number off the top of my head, but it is in the high 90s, the percentage of members who are in managed care.
Okay.
Don't quote me on this. I want to say it's like 97, 98%.
Okay.
So that it is not a meaningful number of members that are in fee for service Medi-Cal. So strategically, it probably doesn't make a lot of sense to spend a lot of
Okay.
time focused on those members, and DHCS is very strategic about trying to ensure that all members are enrolled in a managed care plan.
That's very helpful, Jeff. Thanks.
Great, thanks. And yes, Beth, go ahead.
Two things, following up on Kevin's question and agreeing with DHCS that it's in the high 90s, that of people in Medi-Cal managed care, but there are Medi-Cal programs, things like, and Medi-Cal and other programs like county behavioral health, that don't necessarily flow through the managed care payment structure. The other thing, and I know I'm a broken record on this, but so we don't lose track of it. For those in commercial coverage, there's way too much spending that's out of pocket and out of network that is not captured in THC. THC, I've decided, is a misnomer. It's not total healthcare spending. It's a subset of healthcare spending by plans, an important one and one we care a lot about, but not all healthcare spending. The other thing, I think I was a little puzzled about the staff recommendation at the last board meeting not to set a benchmark until several years from now. I think this laying out what data when you're collecting is very helpful in understanding what's rolling out over the next several years. So I would commend that for the other settings in which you report on this, like the board and the advisory committee. Thank you.
Thank you, Beth. And yes, for OHCA has both work streams, both to look at out of pocket, out of plan spending that is ongoing, and also as a preview of one of our last slides, we will be working with DHCS over the summer and fall to better to kind of understand how we might be able to track non-Medi-Cal managed care behavioral health spending. So through those other programs you've noted. So I will jump ahead one slide. Oh yes, Carrie, go ahead.
Yeah, just to that point, Margaret, I do wonder. I appreciate the acknowledgement of what's not measured and what can't be submitted. And when you're presenting on this, I know it sounds like you'll go into it at the end, but is there a way to just flag somewhere that there are these other types of spending that you'll be measuring elsewhere or trying to measure elsewhere?
Yes, we can make sure to incorporate that into future presentations about what we're measuring and what we're not measuring, at least for this initial this this initial plan that we've laid out here. And we also, in any reporting, would make sure that that is clear about, what is included in the data we're reporting and what's not.
Thanks.
Sure. So and then as just to follow up on the benchmark setting. So as Beth noted, and we've shared previously, that the board has opted to wait at least until next year to adopt a benchmark based on some of the uncertainty that we saw in the data about current levels of spending, and the feel that we might need more time to understand the spending data and to understand what might be realistic in terms of setting spending expectations for the investment benchmark. And so the board in its meeting last month focused on would like to revisit the benchmark next summer with the benefit of additional data and analysis and experience. So this means that the data that payers submit next year that I just previewed will only be used for measurement and reporting and not for comparison to a benchmark. So we will conduct more HPD analysis over the next several months and come back to you all and the board over the summer and kind of revisit the benchmark conversation. And if folks feel ready at that time, then we will, move forward with benchmark recommendations. So moving forward with data collection for measurement purposes of behavioral health spending from the payers, and then moving forward with additional data analysis in the HPD to inform potentially setting a benchmark next summer. So that is the recap of where we are now, and want to maybe just pause quickly to see if there's any other questions. It looks like there's a question in the chat about do payers on slide 7 include managed behavioral health organizations through their commercial partners? And yes, the expectation is that behavioral health spending that is delegated to a managed behavioral health plan would be submitted by the payer. And then, Catherine, to your question about the inclusion of or looking at county mental health plan spending or DMC ODS programs, that is something we'll be working on this summer with DHCS to better understand how we could, track the spending in those programs.
Thanks.
Okay. If I don't see any hands raised or additional questions in the chat, so I will jump to our next agenda item, which is getting into more details about our behavioral health definition and measurement methodology. And we really appreciate over the past few months all of the time and thought that you all have put into the really fine details of the code set for the claims-based definition. So we really appreciate that, and we have a few questions for you all about some diagnoses that we're interested in your feedback on whether to include or not in the definition. We'll start with looking at behavioral health service subcategories for how we measure behavioral health spending and what subcategories we organize behavioral health spending into. And then we'll also provide a refresher on the approach to measuring non-claim spending. And we think we're nearly ready to share a full definition for public review and comment. So interested in your feedback today to help us work towards releasing a full definition, methodology, and code set for public comment by August 1st. So we're looking forward to your input today to help us kind of finalize some key questions leading up to hopefully an August 1st release of the full definition for review and public comment. So just a quick refresher again about this process map in terms of how a claim is identified as behavioral health spending. And the first test is whether the claim includes a behavioral health diagnosis as its primary diagnosis. And the exception to this is for when a claim is for screening or assessment for a mental health condition or substance use disorder, which do not require a primary diagnosis. And then the service subcategories and categories in the center of the diagram are defined by place of service and revenue and service codes, and they're used for reporting and analysis. And then once a claim is determined to have a primary behavioral health diagnosis, this further categorization just helps us identify but does not determine whether a claim is included as behavioral health spend overall. And then pharmacy claims are separately determined to be behavioral health spending based on NDC codes. And importantly here, all claims can be identified for either mental health or substance use disorder, so the can be measured and reported separately. So jumping into our first item under the definition is to get a bit of feedback from you all on the subcategories for categorizing behavioral health spending. So in our meeting last month, we proposed replacing the community-based mobile clinic services subcategory with a broader crisis care subcategory. And the discussion about those services, both in the work group and with other stakeholders, really revealed an interest in analyses of behavioral health crisis services and mobile service utilization and spend that would require more granular data than the OHCA behavioral health data collection. So our thinking here is that moving forward, the HPD would be a more appropriate data source for these analyses. So based on this feedback, we propose reducing the number of subcategories and folding in crisis care subcategory into the other outpatient subcategories, which is flagged at the top in that top red circle. This would also reduce data submitter burden a bit. And then similarly, we're also recommending removing long-term care from the list of subcategories. Spending in this subcategory, it rarely appears in the HPD data, and we'll share some data in a bit. And removing these codes would reduce data submitter burden by simplifying the subcategories. So, and just to emphasize and reiterate, so removing these subcategories does not mean not including this behavioral health spending. It just means that we would not categorize the spending into these more detailed subcategories. So we would capture all of the spending and it would either, go into outpatient, community-based behavioral health care, or would potentially fall into the other services category. And a bit more about the rationale for this. So we think these proposed revisions are appropriate, both in response to kind of the feedback that folks are interested in more details related to spending, especially in the crisis care and mobile clinic services category. Most importantly, just as I just noted, that the changes do not affect total spending, only the categorization of the spending. And simplifying the subcategories can slightly reduce data submitter burden. And then another emphasis is that we can use the HPD data to monitor changes in mobile clinic services and crisis care spend to better understand spending there and on what types of services are being utilized within mobile clinic services and crisis care. And just another note that preliminary HPD analysis showed little or no commercial or Medicare spending in on mobile clinic services from 2018 to 2023, and we'll review this data in a bit. And then note that there was some behavioral health, some spending on mobile clinic services in Medi-Cal, about 4% during those years, 2018 through 2023. And then I'll also note, just as a kind of limitation, is the preliminary HPD analysis used the Milbank subcategories that we've talked about previously. And since crisis care was not included as a Milbank subcategory, we don't have an estimate for that spending. And then also the HPD analysis found very little spending in the long-term care subcategory. So I'll just review that data quickly, and then we'll open it up for discussion. So again, this is the commercial behavioral health spending by subcategory from the preliminary HPD analysis that we've reviewed before. Mobile services, the second from the bottom row, makes up a negligible contribution to total behavioral health spending. It's never as much as 0.1% and approaches 0 in 2023. And then the long-term care subcategory is even smaller, so never more than 0.1% and even less in 2023. So pausing here for discussion, we really welcome your thoughts on removing these subcategories to simplify and complementing the OHCA behavioral health reporting and data collection with more detailed analysis in HPD. And several hand raised, and Kirsten, I think I saw your hand first, so go ahead.
Good morning, Kirsten Barlow with the California Hospital Association. I just would support the proposal to take out specifically mobile clinic and long-term care. Mobile is a really new service that's primarily being rolled out through the Medi-Cal program. And since you're not really capturing at this point the county behavioral health care delivery system, which is really the entity rolling that service out, seems to make sense to not have that as a distinct piece. Wanted to ask just a question though, going back to slide 13, the service subcategories for emergency departments indicate in parentheses that you would be counting spending on only those ED services where there was no inpatient admission. I'm assuming that maybe that's because you're not trying to kind of double count, for so to speak. You're going to already be capturing the inpatient folks who may have started in the ED, but maybe you could explain a little bit more the rationale for that, because in terms of spending health provider effort and services, the ED visit in and of itself does contain a lot of spending, actually, even if that person is subsequently admitted. I see those as very distinct intervention points from the standpoint of who's providing it, for how long, what the purpose is. And so wanting to kind of better understand why we would not want to count ED visits, even that might have a subsequent admission that followed. The other piece would be that, there could be examples where you could, quote, be double counting a person's episode of a behavioral health need or service in other places too, right? Because sometimes people would go directly from inpatient to an outpatient program or a residential program, in which case, you might argue that those are all still part of one episode of intervention for a person. So I would tend to argue for, unless I just don't understand the rationale yet, wanting to include ED visits that may subsequently result in an inpatient admission rather than pulling those out.
Margaret, I'm happy to chat through a little bit of that.
Yeah, thanks,
Hi,
Vinay.
Vinayak Sinha, Senior Consultant at Friedman. So this is all for the claims-based methodology. And so we would capture the ED portion because those claims would include the ED place of service codes for professional claims and then revenue codes for facility claims. We would capture that based on the place of service or revenue code on either the professional or facility claim. So we would include the portion that has claims that are specific to the revenue codes that are emergency department in the emergency department category. When there are then claims for that same individual or episode of care that transition into inpatient services, those claims would have inpatient revenue codes or inpatient place of service codes, and we would capture them in the inpatient bucket. So that spending should not be double counted because the claims would have separate revenue codes and place of service codes, but all of that spend would be counted. It would just be categorized when it has an emergency department related place of service or revenue code in the emergency department category, and when claims have a inpatient place of service or revenue code in the inpatient category. So that allows us to avoid double counting as well as allows us to include all of the care for the individual with a primary behavioral health diagnosis.
Oops. I guess either I'm not understanding or you're validating what I think I was concerned about, which is that you could have an individual go to an emergency department while waiting for an inpatient bed. They could spend several days. There are lots of services and costs and spending that are occurring in that ED visit uniquely. Even if, again, that same patient several days later or that same day, whatever the duration, subsequently goes someplace else, I tend to think that we wouldn't want to pull out claims where place of service started as ED and subsequently went to inpatient. I think those are two very different interventions with spending happening and services happening. And again, kind of to reiterate what I was saying before, there are other places that people go from the ED or from any of these service locations, frankly, that could be considered, quote, an episode of care that are very distinct from one another. You know, as an example, again, a person could leave a psychiatric inpatient hospitalization that maybe was 4 days and go directly to a residential care facility. I would want to make sure we'd be capturing both of those things, right? Not just one or the other. Not just where the person landed.
Yes. So I think we are capturing both of those. We're just categorizing the spending distinctly. So the inpatient admission will be categorized in the inpatient category, and the residential care will be categorized in the residential care. And so the idea is in the emergency department category that we're only capturing emergency department care.
So what is the utility of having in parentheses no inpatient admission?
Just to clarify that for the claims where there are revenue or place of service codes that are for inpatient, those will be in inpatient categories, not in the emergency department category.
So I think it was probably to be more clear, but maybe it's caused more confusion. So we can think about how to be less confusing. But I think, Kirsten, the intention with the data collection is to capture all behavioral health service spending or all spending on behavioral health services, but just to categorize it based on place of service and revenue codes. So we're not, the goal is not to exclude spending through our data collection for behavioral health spending.
Thank you. I think part of why I'm also thinking this is an important thing to flag is to the extent, and we're pleased to see you're going to begin to look at managed care plans in the Medi-Cal program rather than wait, a period of time to look at Medi-Cal. Just a note is that the ED visits for any behavioral health related service or need are covered by the MCPs. Inpatient psych, though, is a county service. So just letting you know that, at least in the Medi-Cal system, we've got two different payers for that same patient, right? They went to the ED, Medi-Cal managed care plans paying for that visit. if they went to inpatient, residential, or any of these other places afterward, now we've got a county payer potentially.
Thank you for that flag. Yes. Beth, go ahead.
I always think that I know how complicated Medi-Cal is, and then it turns out to be more complicated. Speaking to Medi-Cal, I think I understand this logic when we're talking about commercial plans. I'm not sure I understand it. If you could go back to the prior slide, whoever just flipped forward. I'm not sure I understand the logic of excluding community-based services and crisis care, or for that matter, long-term care on the Medi-Cal side. I have a suspicion there's a lot more of it there. So I understand when you're just looking at the commercial data, and we focus a lot on that. So I understand the logic of simplifying the reporting. I do wonder when we get to Medi-Cal whether we will regret not having these boxes, even if they're not checked very often for commercial care. So it's a question. Thank you.
Thank you, Beth. And I think we are hoping that, a part of our work over the summer also includes working with HPD to analyze Medi-Cal behavioral health spending and, understand if we're capturing, how we could do that using the HPD or other work. So, we may learn more over the summer.
Yeah, and I would also say, and this is similar to what Kirsten said, and I suspect what Carrie's about to say, to the extent crisis care is an emerging modality, that historical data may not serve us well in the future. So it's just worth thinking about that as well.
Mm-hmm.
Thank you.
Mm-hmm. Mm-hmm. Carrie?
Yeah, I'll just say, like, ditto to Beth's comments. I think she said it better, but I wanted to I just wanted to make sure I understood what you're proposing, because as I was looking over the slides, it sounds to me that part of this stems from the fact it's not that we don't want to measure these things, but that community-based mobile clinic services and crisis care are better measured through the HPD. Perhaps maybe this is a question. Is that true for Medi-Cal, or just or when we're looking across Medi-Cal and commercial and other payers? So that's a question, because we know in Medi-Cal, I think we know that this is an emerging area, that there's funds and it's part of contracting to provide these services. So I guess I'd like to understand a little bit more about that. But it sounded to me like the recommendation came from this notion that the data is not available. We can only get it through HPD. And so therefore, it's not that you're not going to track it, but that you're not asking the data submitters to report on this. And that which goes back to my question is it just that the data submitters on the commercial side are not tracking because it's not implemented there, or is this an issue in Medi-Cal? I'm just trying to understand, I think, the finer points so that I can evaluate it better, if that makes sense. Thanks.
Yes. So I think to start, we would still include in the broader, set of diagnosis codes and that care, the idea is to, maybe I'll start with the idea through our behavioral health spending is to capture all behavioral health spending despite wherever it occurs across the healthcare system. So we would still capture crisis care services or community-based mobile clinic services. We would just not be asking payers to then further categorize them into a, a crisis care subcategory or into a long-term care subcategory, but we would still be capturing that spending. So that is for overall for OHCA. And then because this spending is small and because it would be, helpful to understand more about like the exact utilization of services, at least that's what we heard from some folks, that the idea is that the utilization data and understanding that more about how often these services are utilized would be more appropriate using the HPD to analyze that level of granularity.
Yeah. Margaret, just to sort of punctuate what you're saying. Yeah, it seems to me none of this is about not capturing spend. It's all about the detailed subcategories for breaking it out. So
Yes.
I think people should be reassured, right? At least I'm feeling reassured. We're not going to omit some dollars that are being spent in these categories. They're just too challenging administratively and small in amount to create a report that routinely breaks these out. But they're there if people want to do additional analysis.
Right.
Sounds
And it would be
paraphrasing of your
yeah, and so this is, I mean, these are the reporting subcategories of the data submitters, whereas you HCI are, committing to continue to provide a breakout on spend, or I guess it's a question. Are you committing to, continuing to provide those breakouts on spending for these categories, on some type of regular basis so that we can track what that looks like?
I think, Carrie, the answer is yes, but the data source would be different than the payer's data submissions to OHCA. The intention would be to work with the HBD folks and to understand how we could track crisis care and long-term care services using the HPD to get to that more granular level of utilization of services.
And sorry, I know Hector has his hand up, so I'll just really quickly, when you say that it would be subsumed under the category, so say, outpatient community-based, does that mean, do you see, like, is it possible then that the mobile clinic services could fall under, outpatient professional primary care, non-primary care, outpatient facility, like it could fall across these different
Yes.
areas? And then, yeah, would you still be able to do an analysis of the pair submitted data, or would that require additional, yeah.
We would not be able to use OHCA's data collection to do an analysis to understand, how much utilization there is of crisis care. That is where we would look to use HPD. But yes, the crisis care or mobile clinic services would be captured across the other outpatient subcategories as relevant, potentially most likely in either outpatient facility or outpatient professional non-primary care. And yeah, yes, Hector, go ahead.
Yeah, thank you so much. This is super helpful. I just wanted to mention that I would be okay with the approach being proposed, given the that it will be captured at the end of the day. But I do have the same concerns and thinking along the same lines as Carrie is, thinking that it would be important to consider how this is being captured in the reporting. And I think even though it's true that the provision of these services, the volume is low, and perhaps the availability is low as well, I think it's important to keep in mind that these are new services that are also now required for private plans to cover, so not just Medi-Cal, but AB 988 requires private plans explicitly to cover mobile crisis services. So, so of course, the expectation is that those would be it would increase, right? The volume and the percentage of spending in this area. So I think it's important to keep that in mind, and perhaps at a future consider bringing back the reporting on the specific category, because I think that's the end goal, right? That we want to see more of these, because these are services that are important, that are community based and meet people where they at, and where they're at, both on the mental health side and on the substance use side.
Thank you, Hector. Yeah, thanks for flagging those considerations. And I think it's a fair point that we could reconsider, adding back in these service subcategories in future years of data collection as we learn more and from HBD analysis. So that is a helpful flag for future consideration. So I think with that, just to keep us moving, I'll turn to our questions on behavioral health diagnoses for our kind of next discussion about the definition. So again here, starting with our process map. So we are now looking at the portion of the process map that's circled in orange, which is the main determinant of whether a claim is defined as a behavioral health service. Specifically, whether the behavioral health diagnosis whether a behavioral health diagnosis is in the primary diagnosis field. So the diagnoses included in the definition are critical to the measurement of behavioral health spending. So the first set of diagnosis codes we want to discuss is related to dementia. There are two groups of diagnosis codes that include conditions related to or causing dementia. So F codes are for mental health disorders due to known physiological conditions such as vascular dementia. And the group of G codes identifies degenerative diseases of the nervous system, such as Alzheimer's disease, which causes dementia. And it's our understanding that behavioral health providers who treat patients with dementia will typically use an F code, such as vascular dementia with behavioral disturbance, as a primary diagnosis. And in contrast, behavioral health providers do not typically use G codes representing the underlying neurological disorders. And then the next set of codes that we want to discuss with you all are for traumatic brain injury, or TBI. And the behavioral health code set that we've currently developed, informed by the Milbank code set and other state definitions, currently includes diagnoses for dementia, but not for TBI. And we've had some discussion in the past with the work group, and some members have suggested that they should be included. However, we recommend excluding them. And there's a few reasons for that. So including the primary diagnoses of TBI may capture more medical spend than we're hoping to capture. And then also, clinicians have advised us that most behavioral health care related to TBI is coded under the relevant behavioral health diagnoses. For example, if a provider treats a patient with TBI for depression, the primary diagnosis on that claim would likely be depression, which is already in our code set. And we'll also note that the Milbank work group chose not to include TBI in its diagnoses list, as they believed that a significant portion of the spend would not be for behavioral health services. And then our next category of diagnosis codes that we're considering adding to the list are Z codes. And Z codes were designed to identify social determinants of health and describe issues related to things like education, employment, housing, finances, and legal issues. And the key question for determining whether to include these codes is the purpose of the behavioral health definition. So wanted to walk through this with you all. So if the purpose of our behavioral health definition is solely for measuring behavioral health spending in California, then it may be appropriate to exclude Z codes. They cannot be used as a primary diagnosis for billing, so there would be no claims associated with their use. These codes may be used on encounters, and therefore excluding them could impact our analysis of behavioral health non-claim spend, or our data collection of behavioral health non-claim spend. On the other hand, if the purpose is broader and to create a definition of behavioral health for state agencies to leverage for spending, utilization, or other related research, it may be more appropriate to include the Z codes. And we'll also note here that physicians are encouraged by organizations such as the American Academy of Family Physicians to use Z codes. And then, of course, the Z codes are an important part of recognizing the impact of social determinants of health on health outcomes and identifying and addressing them, especially as payers move towards more value-based payment. And here I wanted to look at specifically some of the codes that we've reviewed for potential inclusion. So stakeholders have suggested including two types of Z codes, some related to behaviors and some related to personal history, which are listed on the slide. So in thinking about whether to include these, there's some important considerations. So of course, as I just mentioned, physicians are encouraged to use Z codes. Other Z codes are already included in the code set, such as personal history of suicidal behavior and personal history of other mental and behavioral disorders. The note here also is that including Z codes will not impact overall behavioral health claims spend measurement because Z codes cannot be used as a primary diagnosis for billing. And then including Z codes may impact the measurement of behavioral health spend in capitation if they are included as a primary diagnosis in a capitation encounter. So, as a refresher, OHCA's methodology for capturing capitation spend for behavioral health services uses encounters, which are not used for payments, but could include Z codes in the primary diagnosis position. So with all of that, I know lots of detail, but we have questions for you all about these three areas. So the first is, should OHCA exclude TBI and similar diagnoses in behavioral health measurement? Should OHCA only include the F codes associated with dementia and exclude G codes for underlying neurological disorders? And last, should OHCA exclude or include Z codes in the code set? And if so, should all related behavioral health Z codes be included or only some types? So I'll pause here for discussion and folks to weigh in with their thoughts. Yes, Jeff, go ahead.
So for the Z codes, I put it in the chat. If it's just to capture a little bit more of the capitated component, I just don't think it's worth the complexities that it adds. I don't think it's going to add a lot of fidelity. And as you note, it doesn't really make sense from an encounter-based approach because you can't use those in the primary position anyway. So while we use Z codes, they're used kind of as supplementary to give context to what's going on with the patient rather than to define what conditions they have. At least that's technically how they're supposed to be used. I don't think it makes a lot of sense. I think we're just adding complexity that we're splitting a hair and it doesn't add a lot of benefit. And then for number two, this is kind of me being a clinician. Let me go back to the slide. So slide 19. Was that analysis what you said about G codes that behavioral health providers do not typically use when treating patients with dementia? What was that based on? Is that based on a data analysis? I'm a primary care provider. Like, to me, as a physician, I'm like, is that true? I don't know that that's really true. Like, we're always told as clinicians to choose the most specific code possible. And some of those F codes are not very specific, and the G codes are much more specific to a specific condition. Like, don't say dementia, say Alzheimer's. That's the specific condition the patient has. And I would think, and some of the psychiatry folks on can help me if I'm missing something, the same would apply in psychiatry and behavioral health specialty care too. So that doesn't quite line up for me as a clinician.
Thanks, Jeff. Yeah, we reached out to several behavioral health clinicians to get input on this. So this is where this data comes from, and then if the Friedman healthcare team can also weigh in here. I think we also looked at some coding guidance about how to code, or the guidance for coding. But yes, this information comes from input from behavioral health clinicians. But welcome, Parnika, yes, feel free to jump in.
Thank you. Parnika Saxena, geriatric psychiatrist. So certainly want to, happy to comment on this. I agree. I think it would be better if we could use G codes, and we've tried to. The very honest answer is that it has been hard to get insurance covering G codes when psychiatrists use it. It would be more appropriate for us to use it, but this has been a problem which I have talked about even in earlier meetings, that there seems to be a disconnect with understanding that dementia is not a purely neurological illness. It is, in fact, often presents with behavioral issues, and that's where psychiatrists play a role. As geriatric psychiatrists, we technically are trained to even do more detailed assessment to diagnose people with dementia. But for whatever reason, the billing gods have not allowed us to get any claims paid when we use G codes. I also polled a couple of my colleagues who work in different settings and settings different from me, and they had the same concern. There was one G code that at one point in a collaborative care setting was acceptable. But I think when we as psychiatrists have worked separately, whether it's an FQHC, whether it's just a standalone clinic, it's been difficult to get any payment back. So the F code ends up being the primary because that gets paid back a lot more easily. And I think it's more of the reality of the situation. But I agree, to be true to coding, we should be using more G codes. That's the limitation.
Thank you, Parnika. Do anybody else have thoughts on any of these questions? Yes, really looking for folks to weigh in with their expertise here. Yes, Beth.
Yeah, I hesitate to say this, but given all the emphasis, and I would say emerging emphasis on social determinants of health, not only here, but covered California and elsewhere, I do wonder about the Z codes, and it may be that it's not appropriate at this point, but that's the kind of question that might be worth revisiting in a few years as the discussion and use evolves. Because I do think, we know how much health outcomes are related to social determinants of health. So it may not, this maybe should go on the list of, well, it may not make sense today, but I'm just not sure that'll be right in 2 or 3 years. That's a thought. Thank you.
Thank you, Beth. Yes, Parnika, did you want to weigh in here as well?
Yes, so I would actually, my vote would be to include Z codes. The reason being, especially when we're working with patients with SDOH, as behavioral health, as a behavioral health clinician, as a psychiatrist, there's a lot more time spent in talking to these patients. There's a lot of this time is not compensated. And I think, especially depending on what kind of setting you're in, if you're in a private practice, you probably can do that. But if you're not in a private practice, there's a lot of time that's spent between appointments, during the appointment, that isn't accurately, is not accurately reflected in the codes or like the treatment or diagnosis codes that we enter, right? So for a lot of times, I've had patients who I saw for a whole hour. Because they had issues that were SDOH related, and they aren't always accurately reflected. So my vote would be to include Z codes because they do include that invisible time labor that behavioral health clinicians undergo. And I'm hoping that there can be a better way of compensating for it in the future. And that's why I think its collection is important, so it can educate claim compensation, behavioral health spending in the future.
Thank you, Parnika. And maybe just one follow-up question. Would you include all behavioral health related Z codes or specific Z codes?
I haven't seen all the Z codes, but the ones that, I tend to use a lot of like the ones that you pointed out, personal history, things like that, tobacco use, definitely. Personal history of abuse, things like that for sure. But I can look up some more and give you a more accurate answer to that.
Sure, that would be wonderful. Thank you. Carrie, go ahead.
Yeah, thank you. I on this particular topic, I agree with the others who have spoken. I think we are being able to document in a chart a Z code. So often these social determinants or other information is is part of a treatment plan. And so I think we want, in a world where we want to encourage looking upstream and trying to we know that having like housing is really key to a key benefit for mental health, right? So I think if we're if we're thinking about this, both to include it and also to think about, how are we capturing, if we want to encourage that the screening and really, making sure that folks are getting, follow up to help manage their mental health issues in these other areas. And I think it is important that we somehow, are tracking or keeping, just, documenting this. I know you have very specific Z codes related to behavior and personal history, but also similarly, because we know, again, that housing is, beneficial to mental health, and there are other types of health-related social needs that are beneficial to improving mental health. I think it would be, it might be important to have another conversation about this where we can think about it more together as a group. Thanks.
Thank you, Carrie. And Vicki, yes, go ahead.
I think we should definitely collect Z codes, and they shouldn't be just the behavioral ones. because if you kind of go from Z to social determinants of health, like housing first, like we know that in some mental health interventions, that's critical. And so we want to know the extent to which those things are being documented and being, implemented. But to use the Z codes are not going to be as easy as it sounds. We're just finishing up a paper for some ICD work, and we've looked at Z codes in 9 and 10 and in 11. And there's a lot of work that needs to be done in terms of crosswalks and all that. But I think it is the way to go, but I think it's all Z codes, not just the behavioral ones that you should consider collecting.
Thank you for this feedback, Vicki. And I know we've got lots of folks weighing in the chat with answers to these 3 questions, so I really appreciate that. Yes, Kevin, go ahead.
Yeah, I mean, I think this is an emerging area. I mean, I agree with what everybody's saying in the sense of it. There's encouragement to provide more of this context. I just don't think right now it's going to change anything about measuring behavioral spend. They're not going to appear as primary diagnoses, as Jeff says. There are actually other primary diagnoses you can use that are not Z codes for gambling, pathologic gambling or other things like that. So I think for this context of measuring behavioral health spend, I don't think it makes sense to include them. I think there's sort of a broader issue of trying to capture emerging ways of documenting all these contextual factors that are going on with people's lives. That's sort of a separate project for HCA.
Thank you, Kevin. And yes, and I think for everyone, I appreciate you all weighing in the chat. And I think what we will do is review everyone's feedback in the chat, consider all the discussion we had today, and consider options, and going back to HBD, we could do some exploration of understanding the utilization of Z codes using HPD, but we'll consider all of this feedback and look forward to following up with you all on this. And I think for the sake of time, to keep us moving, we have 2 more fairly large items to cover, so I want to try to make sure we can get to as most of the topics as possible. We'll turn it over to Bob Seifert to walk through the behavioral health non-claims spending, and then we'll also discuss the behavioral health and primary care module.
Thanks, Margareta. Good morning, everyone. Bob Seifert, one of the consultants with Friedman supporting the OHCA effort. So as we approach the end of the work group's efforts on defining behavioral health spending, we wanted to review the proposed approach for identifying non-claims-based spending for behavioral health with you one more time. And then we're going, if time permitting, we'll review the behavioral health and primary care module as well and address any remaining questions there. So on the next slide, thank you. These are the specific approaches. Again, this should look very familiar to you, that OHCA recommends for allocating the non-claim spending using the expanded framework subcategories. In expanded framework category A, the population health and practice infrastructure payments, the payments for subcategories A1 through A3 would be considered behavioral health spending if and only if they are made to behavioral health providers and provider organizations. Within that, in subcategory A2, those payments for primary care and behavioral health integration would be included in the behavioral health and primary care module as part of behavioral health spend. And then spending in subcategories A4 and A5 would be limited to a maximum allowable amount. What OHCA is recommending is that the limit be equal to the portion of total claims and capitation payments going to behavioral health. In other words, the amount of practice transformation and infrastructure payments, subcategory A4, attributable to behavioral health would reflect the proportion of spending for behavioral health care in claims and capitation overall. The formula for this allocation, which we've looked at in past meetings, is in the appendix of this slide deck for your reference. And then category B, the performance payments would be recognized as behavioral health care payments when they are made to behavioral health care providers. Moving on to category C, on the next slide, these are the shared savings arrangements. Condition-related episode-based payments would be included in the measurement of behavioral health spending if the episode of care in question is behavioral health related. We are not aware of existing or planned procedure-related episode payments for behavioral health, nor are we aware of health plan arrangements with behavioral health practices agreeing to take on risk for the total cost of care. So that's category C. On the next slide, we look at category D and E. For behavioral health capitation payments, that's subcategory D4, behavioral health capitation specifically, 100% of the payment would be included in behavioral health spend measurement. And then for more general types of capitation, so the professional and global capitation, and for payments to integrated comprehensive systems, the behavioral health portion would be allocated using a similar formula to the one we use for allocating capitation payments to primary care using encounter data. And again, the formula for this allocation is in the appendix. And then as with primary care, facility capitation, payments would not have a portion allocated to behavioral health spending. And payments in category E, which is labeled other non-claims payments, they would be limited to a maximum level using the same proportional method OHCA is recommending for the infrastructure and practice transformation payments for subcategories A4 and A5. So that is just kind of a brief overview of the non-claims approach. We can pause here for a few moments to invite any remaining comments that anyone might have on the recommended overall approach for defining non-claims behavioral health spending. Okay.
Yeah.
Hearing none. So, go ahead, Margaret.
Hopefully that's clear. And of course, if folks think of suggestions or questions after the meeting, feel free to follow up. But yes, we'll move on to the behavioral health and primary care module.
Great. So in the interest of completeness, let's look now at this module, both with a general look at its purpose and structure, and we're also looking for your feedback on the question of further expanding the list of primary care provider taxonomies to support the module. So first of all, just as a reminder, we've looked first at the process for behavioral health claims and just now at defining non-claim spending. This is that third module, which consists actually of both claims and non-claim spending, measured separately from the rest of behavioral health spending so that it can be included in analyses of both behavioral health and primary care spending. The reason for the behavioral health in primary care module on the next slide is that the measurement of the module can promote policy priorities such as integrated care and greater attention to preventive behavioral health care. The way that OHCA can do that with this module is that it can calculate the behavioral health spending occurring in a primary care setting, which first of all prevents undercounting behavioral health spend and also highlights integrated behavioral health in primary care. And the module also allows OHCA to combine behavioral health and primary care spending without double counting the spending that fits into both categories. So in the next slide, we have the diagram that you've seen before that illustrates this last point. The module, which is represented by the green square in the center, is shown as being part of both behavioral health and the primary care rectangles. To identify behavioral health spending in primary care, we would first, on the left side of this diagram, identify behavioral health spending that falls within the current OHCA primary care definition based on primary care provider taxonomies and place of service codes. This would include CPT codes, service codes that are clearly and always behavioral health, such as mental health and substance use screening and integrated behavioral health services. Moving to the next box over, it would also include office visits, case management, and other services that would be considered behavioral health services when the primary diagnosis is a behavioral health condition. And we're calling these sometimes behavioral health primary care services. And then the module would include non-claims payments for primary care and behavioral health integration. In addition, a share of capitation payments would be included by applying the capitation allocation formula we talked about earlier and described in the appendix. In this case, encounters with behavioral health in primary care codes, so those codes that represent behavioral health in primary care services, would be used in the formula that's in that equation in the appendix. So then the second step to the approach is to expand the list of the primary care provider taxonomies to include certain behavioral health professions. This would capture the services that these providers deliver with primary care codes, such as integrated behavioral health services, screenings, assessments, and also limited brief behavioral health interventions. By expanding the primary care taxonomy list, these services, when accompanied by a behavioral health primary diagnosis, importantly, would be counted as both primary care and behavioral health and thus be part of the module. Once a service has been determined to be behavioral health care using the claims primary diagnosis field or the non-claims methodology, it counts as behavioral health spending. The determination of whether to include or exclude the service from this behavioral health and primary care module is a separate exercise that does not affect the determination of whether or not something is behavioral health spending in general. Inclusion in the module is determined by the provider taxonomy and the place of service on the claim. Also, remember that it will be possible to measure mental health and substance use disorder spending separately, even within the behavioral health and primary care module. So now we're going to review and seek your input on the list of taxonomies that will define primary care providers for the behavioral health in primary care module. OHCA is recommending expanding the list of primary care taxonomies used to define primary care. The expanded taxonomy list will better capture behavioral health services delivered by behavioral health providers in integrated behavioral health and primary care settings. In proposing this expansion, we want to note several things. First, as I mentioned, the expansion of the provider taxonomies will not affect the measurement of total behavioral health care spending because that definition is not restricted by provider type. The taxonomy list is used to identify spending that will be included in this module and also will be used for defining primary care spend. This is important because the definitions of primary care providers should be consistent across primary care and behavioral health to ensure that the measurement is mutually exclusive and collectively exhaustive. So in the next slide, this is an illustration of what is included in the behavioral health in primary care module. The dark blue circle represents the behavioral health spending that is captured in the current primary care definition, which includes the current set of primary care provider taxonomies. Now, imagine that a behavioral health provider delivers a service included in the primary care code set while practicing in an integrated setting. Without the taxonomy expansion, which is represented here by the light blue crescent in the diagram, the spending for that service would be included as behavioral health spending, but not as primary care spending. This would create an inconsistency for reporting because the service would count as behavioral health in primary care from the behavioral health perspective, but not from the primary care perspective. So expanding the taxonomy list enables OHCA to add behavioral health in primary care spending to either to primary care or to behavioral health spend, and to keep those buckets both mutually exclusive and collectively exhaustive. So starting on this slide, the taxonomy, we've looked at taxonomy expansions before, and they are part of the behavioral health code set that OHCA has reviewed previously with you and has asked you to review, and OHCA has reviewed with other stakeholders as well. These two slides show suggestions that stakeholders have made for additional taxonomies to expand the primary care provider list. The taxonomies on this slide are related to applied behavioral analysis, or ABA. OHCA recommends excluding these taxonomies from the primary care provider list because currently ABA providers do not typically provide services in an integrated setting. There is some indication in the literature, that's the citation at the bottom of this slide, that in the future, ABA may become more integrated into pediatric primary care. OHCA would monitor this trend and revisit including ABA providers in the future if appropriate. Just for context, only two publicly available primary care spending measurement definitions include these taxonomies in their primary care provider lists. In the next slide, we look at a few other taxonomies. Stakeholders have also proposed adding professional counselors, school counselors, and 2 psychoanalyst taxonomies to the primary care provider list. OHCA is leaning toward including the school counselor taxonomy because schools are, in fact, a place of service in OHCA's primary care definition. OHCA does not recommend adding the professional counselor taxonomy or the 2 psychoanalyst taxonomies. Again, remember, this is to be included in a primary care provider list. Psychoanalysis services are unlikely to be delivered in a primary care setting, and OHCA already includes the general counselor, mental health counselor, and addiction counselor taxonomies that we expect may be more common in integrated primary care. So a lot there. We'll pause here for some discussion of the behavioral health in primary care module. We're interested, of course, in any comments you might have about the purpose and structure of the module generally, and then specifically about these recommendations regarding the primary care taxonomy list for ABA providers, professional counselor and school counselor, and psychoanalyst taxonomies. Margareta, I'll turn it back to you for moderating this conversation.
Thank you, Bob. Yeah, it looks like Beth, you raised your hand first, so please go ahead.
Yeah, I just want to make sure that I'm understanding what the proposal is. So the discussion on excluding ABA providers and some other categories, we would still count those people, but just as behavioral health, not in the primary care, in behavioral. Yeah, nodding your head is not good enough for everybody. So you just verbally, yes. Okay, so this is where I always thought, behavioral health and primary care was really important. And also it's good that we're doing it last because it's, it's sorting out what belongs in which bucket is challenging. So long as we're counting them somewhere, then that's very helpful to know as we as we think about this. And I'll defer to people who actually do primary care and behavioral health in primary care to continue the discussion. Thank you.
Thank you, Beth. Yes, so these are potential provider taxonomies that we would consider adding to the primary care definition so that we can capture integrated behavioral health in a primary care setting. And Kevin, go ahead.
Yeah. Hey, Bob, can you go back to 33, slide 33? Or whoever's in control of the
Margareta's
slides.
driving the slides. Yeah.
Yeah. Great. So, because this is to me not just about adding some of these additional taxonomies, but I want to be totally clear. I mean, I get the goal of this is to have consistency across primary care spend and behavioral health spend for this subcategory of integrated behavioral health and primary care. But walk me through like that green, category on the side there. Let me give you two examples. Just like I'm a psychologist and I submit a claim for generalized anxiety disorders, the primary diagnosis, and I'm working in the place of service is a federally qualified health center. All right, that would count as both behavioral health spend and primary care spend, right?
Correct.
All right, and I totally agree with that. What if I'm a psychologist working in my own, let's say, private practice? So again, first, the diagnosis is generalized anxiety disorder. My provider taxonomy is a clinical psychologist, but the place of service is ambulatory office-based place of service. Would that count as primary care?
I'm going to defer to Vinayak on this specific coding question, but the requirement is that it both have a primary behavioral health diagnosis as well as a primary care place of service code in the claim.
But see, I think yeah. for me, like as a family physician, it would be office-based would count as a primary care place of service. I think we're excluding hospital-based or something like that. But this would worry me a lot because then suddenly if that's true, I mean, Vinay, whoever's the tech person with the sort of really the details. But this is where I worry about the slippery slope of including all office-based behavioral health clinicians in primary care spend count. That doesn't seem correct to me.
So the other added nuance is that it also has to be a primary care service. And Vinayak, please weigh in here. So the service itself also has to be included in the primary care definition that we've developed.
Yep, Margareta, that's exactly right. So for it to count in the behavioral health in primary care module, there would need to be a behavioral health diagnosis from one of the taxonomies listed here in the expanded list at a place of service. And you're right, an office would be a primary care place of service, but it would have to be for a specific set of CPT and HCPCS codes that OHCA is identifying as behavioral health and primary care services. Those were part of the code set that you all reviewed in the outpatient professional primary care category.
And where do those codes just refresh my memory because this is getting that's an ICD code or it's
Those would be CPT and HCPCS service codes or procedure codes that were previously already included in the primary care definition. So if it was a very specialized behavioral health service, likely not on that service code and therefore not in the module, but in behavioral health claim spending separately.
All right. So I think, am I correct then, Vinayak, is that it would really capture that psychologist who's embedded in a primary care clinical team and not an independent psychologist doing their own therapy with a patient?
That is the hope. We expect that there would be some apportioning there as well through regular evaluation and management type of codes, but that'll depend on specific CPT codes.
We may want to read, I know we went through this with this is back to the primary care definition, right? Where we went through this a lot, but we may want to just dust this off either at the next meeting or have a subgroup, just because this is, I mean, I want to be a little careful here that I'm 100% like behavioral health clinicians, other staff who are part of a, primary care based team doing this. Absolutely 100%. This is a key area of primary care. I just want to be clear we're not including a lot of stuff that's really not connected to primary care that is, important behavioral health, but I would be reluctant to put it under the primary care count.
Sure. So I think we can bring back the combination of, place of service codes, and then these taxonomies in a future discussion. I know we're getting quite close on time. I guess maybe we'll start with Yagnesh, and also, I don't know, Carrie or Vicky, welcome you all to add into the chat, and we can come back to this in our next meeting with a bit more details.
Thanks, Margaret. I'll make mine fairly quick. I don't know how many BCBAs are on the call here, but as a behavior analyst and somebody with a background in ABA, I appreciate, Robert, you were mentioning that there's a research out there that's saying how ABA providers are going to be trying to integrate into primary care practices. I can say from the trade association, from practices, from everything that I see both here in California and nationally, for if not years, maybe decades away from that. So I don't think it needs to be in there.
Good to know. Good feedback. Thank you, Agnesh.
Okay. And I saw some questions in the chat, and I think we'll work towards addressing those in our next meeting since we are at time. So I'll maybe just quickly run through 3 slides and welcome you all to follow up via email. And then we also look forward to releasing the draft behavioral health definition for public comment, and we'll review it again at our next meeting. So this is just a timeline of what we're working towards in terms of the behavioral health definition to then start collecting behavioral health spending data next fall. A quick preview of our August meeting. We'll have a data presentation. We'll talk about follow-up analytic questions, and then we'll also discuss the goal of working towards potentially a benchmark proposal in next summer, in summer 2026. And then we'll also follow up in August about the idea for future work group meetings. We're proposing that we might shift a little bit based on the kind of amount of work, detailed work that OHCA is looking to do to prepare for next summer. So thinking about a quarterly convening with interim milestones moving towards a benchmark recommendation in summer 2026. And then we may also bring updates from other work like OHCA's data collection on primary care and alternative payment models to the work group. So we're looking forward to discussing that next month with you all. And I know we have taken up 2 more minutes of your time, so really appreciate everyone's feedback and the discussion today. We'll go through all the chats and we'll come up with some recommendations for moving forward and incorporating these into our release of the definition in August for public comment. So thank you all, and hope you all have a great rest of your day, and appreciate all of the great discussion today.